Got it.
All right, thank you very much. Okay, so I will just go ahead and get started, and then if people come in, I'm sure you can go ahead and admit them into the room. So all that to be said, let's get into business. So good morning. My name is David Carpenter, and today I'm excited to talk about something we don't discuss nearly enough. That, of course, being the vital role that nutrition plays in recovery. This presentation, The Importance of Nutrition in Recovery, explores how food impacts healing, both physically and mentally. So we're going to go over a handful of things today, and I'll probably try to breeze through some of them and a little quicker than other components. But just to give you kind of an overview of what we'll be covering. So we're going to start. I'll introduce myself, tell you a little bit about Meals on Wheels of Central Indiana. We'll then explore the basics of nutrition, which most people know based on the lovely health classes we took in high school and probably in college as well. But we'll go over some basics. Then we will explore how substance use disorder impacts nutrition, the realities of food insecurity and the impact that it has on people in recovery, and finally, how the No Limits to Recovery program is working to address the importance of nutrition in recovery and make a difference. Thanks to wonderful partners like the Indiana Association of Recovery Residences, Mental Health America of Indiana, we have the opportunity to do the work that we get to do today. So who we are. So I am with Meals on Wheels of Central Indiana. That's a name most people are familiar with when they hear Meals on Wheels. But I will kind of clear up a misconception here at the beginning. So every Meals on Wheels organization across the United States is autonomous. So we are all independent. We share a name, but we all have different programs and different missions from one another. So our mission at Meals on Wheels of Central Indiana is that we educate, innovate, and advocate for our vulnerable neighbors by delivering medically tailored, nourishing, and culturally appropriate food while promoting social connectedness. And the reason I italicize the word medically tailored is because you may hear that a couple of times during today's presentation. That's basically a fancy way of saying that the meals that we provide individuals are tailored to meet their unique dietary needs. And then just a little bit about me. As I said, my name is David Carpenter. I actually started as a volunteer at Meals on Wheels of Central Indiana in 2017. I was doing my human practices program at Ivy Tech and started volunteering here. I was hired as a full-time employee in 2018, and I have been here ever since, was promoted to Director of Quality and Programs in 2021, and I'm currently an MSW student at the IU Indianapolis campus. So it's a real quick me in a nutshell. So we'll get into things. And like I said, this section specifically is, we might kind of breeze a little bit through. This is your basics of nutrition, basically, nutrition 101. I am not a registered dietitian, but I did make sure, throughout this entire process to pay attention to to pay attention and do some research on the basics of nutrition. So first and foremost, just again, this is just a quick overview about how we should be eating and the difference between what I will call food versus nutrition, but we'll get to that. So there's 4 guidelines according to the USDA that every individual should be following to maintain a healthy diet. The first, of course, being that at every stage of life, we should follow a healthy dietary pattern. Stages of life, as you know, you have infancy, toddlerhood, childhood, adolescence, adulthood, and of course, older adulthood. Obviously, in infancy and toddlerhood and childhood, you don't necessarily have much choice over what you are consuming. So that just means as parents and as guardians, it is our responsibility to make sure that our children are eating healthy. The second point is that food and beverage choices should be nutrient dense while reflecting one's personal choices, cultural traditions, and budget. So what that means is that healthy dietary patterns, they look different for different people. So everyone is unique. So a westernized healthy diet will likely look different and does look different than a Mediterranean diet. So our diet should still respect our choices as individuals and the cultures that we belong to. The third point is that we should meet food group needs by choosing nutrient-dense foods and beverages while staying within calorie limits. So nutrient-dense is different than calorie-dense. You can actually find nutrient-dense food items without overdoing it in the calorie department. We'll talk more about that a little later on. And then, of course, we should do our best to limit foods and beverages high in sugars, fat, and sodium while limiting alcoholic beverages. Sugars and saturated fats should actually make up less than 10% of your calories per day, and you should consume less than 2,300 milligrams of sodium per day. And believe it or not, there are lots of meals that you can get at restaurants out there that completely blow those numbers out of the ballpark, and that's just one meal. So we need to be conscientious about what we're eating. So growing up, I was taught the importance of the food pyramid. However, as it turns out, according to the United States Department of Agriculture, or USDA for short, the food pyramid is no longer relevant. So my plate is in and the food pyramid is out. Kind of to summarize this, basically half of your plate when you are eating any dish, breakfast, lunch, or dinner, should be composed of fruits and vegetables. You should vary your veggies and focus on whole fruits like bananas, apples, grapes, the whole, we all know what fruits are. And then, of course, the other half of your plate should be made up of grains and a protein. And you should vary your protein. So, fish, chicken, beef, tofu, so anything to get your protein intake. And then, of course, on the side, dairy continues to be suggested that we should move to low-fat or fat-free dairy milk or yogurt along with what we are eating, again, for breakfast, lunch, and dinner. So again, the food pyramid is out and my plate is in. So food versus nutrition, and I kind of hinted at this earlier, and this is just something that I kind of abide by or live by in my head, is there's a difference when I think of food and then when I think of nutrition. So food is, when I think of food, the picture there is kind of a great analogy, is I think of anything that we put in our body so that we're no longer hungry, and oftentimes that can be fast food, snacks, sugars. And then nutrition is when we are intentional about the items that we are consuming, be that grilled chicken, a salad, making sure that we're receiving nutrients and eating healthy. And so throughout the rest of this presentation, I'm probably going to lean more towards the nutrition, but when I bring up food, I will say we need to be intentional about the items that we eat throughout the day. So nutrient-dense foods. So what are nutrient-dense foods? I got this picture off of USDA's website, and it did a weird checkered box thing around half of the text and images, so I apologize about that, but it's still legible, so I still used it. So nutrient-dense foods are foods with high amounts of vitamins, minerals, fiber, and other beneficial nutrients relative to the number of calories they contain. So here's some great nutrient-dense, examples here. You have plain shredded wheat, low-fat yogurt with fruit, low-sodium black beans, vegetable oil, and sparkling water. I don't know about you, but I love sparkling water. As everybody knows about me, that's often what I have on hand. Typical foods that we often eat throughout the day. People may eat the shredded wheat, but who doesn't love frosted wheat, shredded wheat? But at the same time, that's higher in calories and not as nutrient dense. Who doesn't love full-fat yogurt with sugars and flavors? But again, that adds calories over nutrients. And oftentimes regular canned vegetables are very high in sodium. That's something we need to be careful about and conscientious of. And then, of course, butter. Who doesn't love butter? But at the same time, in moderation. And then soda. And actually, I've removed soda from my diet years ago, and I am still grateful with that choice that I made. Every now and again, though, again, in moderation, I may have a soda. So I'm going to take a quick drink real fast. Speaking of sparkling water. So one thing that we believe in here at Meals on Wheels is that food is medicine. And so that quote actually comes from something that Hippocrates supposedly said, which was, let food be thy medicine and let medicine be thy food, which is very elegant, right? And it makes sense. It's like what we, at the end of the day, we are what we eat. Well, the reality is, if you actually do some research on this quote that people attribute to Hippocrates, Hippocrates actually never said that. So Hippocrates said, in food, excellent medicine can be found, and in food, bad medicine can be found. So let food be thy medicine and let medicine be thy food is similar, but obviously somebody took it and kind of jazzed it up a little bit. What's interesting is that Hippocrates said this thousands of years ago before science could back up his claim, and thousands of years later, his claim continues to actually be supported by science. We are, again, what we eat. So like I said, ultimately, we are what we eat, and what we eat affects and shapes everything about us. So we need to be conscientious about what we are putting in our body. If you're eating fast food all the time, or you're eating chips and all those good, fun, sodium, sugary sweets, that will often drag you down. It may feel good in the moment, but it does catch up with us. So all that being said, one thing that we also believe in, at the one animated slide I have. One thing that we also believe in at Meals on Wheels, and I also believe in, is this holism, or this holistic view of health, that we are the sum of all of our parts, right? We aren't just our fitness overall and our health isn't just focused on one of these components, right? We are our physical, financial, social, occupational, environmental, intellectual, spiritual, and emotional health. All of those components make up who we are. And when one area is lacking, all the others are affected. Now, you'll notice that nutrition itself is not on this wheel. Nutrition would, however, fall under physical. So it is a component of physical health, but it also impacts all other components on the wheel. And so I mean something in particular when I say that. So this is just kind of an analogy or an image that I use when I think of wellness and I think of that holistic model. So I think all of us are used to mobiles. Most oftentimes when people think of mobiles, they think of, above a baby's crib, but you can also see mobiles in lots of art museums. There are some really intricate mobiles out there that artists have created, but they're all basically the same kind of idea. Like looking at this mobile, you have stars and clouds, and they're all attached, right? So it's kind of underneath that thinking of it from that wellness perspective, all of these stars and clouds are attached to the same circle and they are all interrelated. And so what happens with the mobile is when you gently push it, it just rotates and everything just does what it's supposed to do. However, if you tug on one of those components, or you try to remove something, or you try to add something, the entire mobile is affected, right? So think of like when a baby reaches up and were to grab one of the stars, that entire mobile is going to shake violently. And that's kind of the way that I look at wellness. An unhealthy diet will rock the entire mobile because everything is affected by an unhealthy diet. So nutrition ultimately is a prerequisite for our health. And so we have to ask ourselves, especially as persons working in the recovery field, how can someone truly recover without appropriate nutrition? Nutrition is one of the basic components of wellness. It's part of that holistic circle. And so in order for us to truly recover, we need to be conscientious about what we're eating and what we're putting into our bodies, which leads me to the next point. So the next section, we're going to go over nutrition and substance use disorder. So this one maybe, like I said, the last section was just kind of an overview of nutrition. This one's going to kind of get way more actually into the details of how nutrition and substance use disorder, what happens when individuals are using, and what happens in early recovery. And then full transparency, I may use myself as an example a few times throughout this. I am also a person in recovery. And so there are some times that I may just like make a reference to how something affected me when I was actively using, or when I was in early recovery. So what is the problem? So the problem is right here. So I'll just read it out loud. So the problem is that as a result of substance use disorder, most individuals in active addiction and early recovery are considered malnourished and food insecure. And I highlighted those two words in red for a reason, because we're going to dig into them a little bit more. A lot of people think, I'm trying to think of how to word this. A lot of people presume that we know, and myself included before I started working at Meals on Wheels, what malnourished and food insecure mean, right? However, I've learned through my own experiences working in this field that these terms have very solid definitions and ways of being understood. So with that, we're actually going to start with malnourishment. So what is malnourishment? Dictionary definition here, actually from the United States Department of Agriculture, so the USDA. Malnourishment is a disturbance of form or function arising from the deficiency of one or more nutrients. So when most people think of malnourishment, I feel like, and myself included, we tend to picture individuals or children in developing countries or third world countries, however you refer to developing areas of the world. We think of, children with distended stomachs. And while that truly is an image of malnourishment, that's not the only way that malnourishment shows up in individuals' lives. So a misconception that a lot of people have is that malnutrition isn't a problem in the United States, right? We live in excess. Food is on every corner. You can go to the gas station and pick up a candy bar. Well, the reality is, in 2024, 11.1 million households in the US were considered food insecure. So food insecurity plays a role into malnutrition. You may be able to go to the gas station and pick up a Hershey bar and a bag of Lay's, but eating those items continuously will affect your overall nutrition in a negative way, contributing or leading to malnutrition. So how does malnutrition show up when individuals are actively using substance use disorder? So oftentimes substance use will inhibit the absorption of vital nutrients and that contribute to our liver function, which is already an issue, especially for individuals that may be using alcohol. They can alter our metabolism and so on. So what happens is when we're abusing substances, our bodies stop absorbing the nutrients that they need, especially within our brains. So in our brains, when we're abusing substances, it tends to actually strip away essential fats that our brains need to make very important neurotransmitters. One of those neurotransmitters being dopamine. So just a quick lesson on dopamine here. Dopamine is central to the brain's reward system. In the basal ganglia of the brain, it actually regulates smooth muscle movement. So issues with dopamine production contribute to diseases such as Parkinson's disease. And so think about when you see somebody, and myself included, in early recovery, oftentimes individuals have the shakes, and that can be from withdrawal, but that can also be due to the low amount of dopamine in their brains, the low amount of that neurotransmitter. Dopamine also helps us focus our attention and process information. So again, myself included, like in early recovery, I had a hard time focusing, and a lot of that had to do with the fact that the dopamine in my brain was very much depleted. Dopamine also interacts with other neurotransmitters such as serotonin to affect mood stability. So all that to say that this poor nutritional status negatively impacts our psychological health because it is affecting our brain and our physiological health. So throughout this thing, I did want to point or bring in some quotes from the professionals. So I did look at some peer-reviewed articles to kind of back up these claims. All the information that I'm giving you today is from research and peer-reviewed articles and is evidence-based, but straight from the mouths of the professionals. In this article, they said that people with substance use disorder, or SUD for short, have been found to have lower dietary intakes of fruits, vegetables, grain, and dairy products, while consuming more high-fat sweets and salty snack foods. They are more prone to vitamin deficiencies, anemia, malnutrition with observable emaciation, lower body mass index, gastrointestinal distress, tooth decay, and decreased appetite. So I just kind of want to break down those sections that I highlighted in red, starting with vitamin deficiencies. So in a study of 67 residents in a large residential facility, after 30 days of being in the facility, 50% were still deficient in iron, 21 were still deficient in vitamin A, and 18% were still deficient in vitamin C. And this was done in a facility where individuals are being fed 3 meals a day, meals that were high in nutrition, and they were still that deficient in essential vitamins. So another component and this is that malnutrition with emaciation. So in that same study, 24% of residents, upon becoming residents of this facility, were considered mildly to moderately malnourished. On our No Limits program, which we'll talk about here at the end of this presentation, we come to also find that a lot of individuals, when they start, are technically diagnosed as malnourished. Gastrointestinal distress. So that's something that I feel like if you work in the recovery field or yourself in recovery may have personal experiences with that. So alcohol and other substances actually damage our gut lining, and our gut lining is responsible for absorbing nutrients. So there you go. It all plays together, right? So if your gut can absorb nutrients, those nutrients can't contribute to building fats in your brain, which therefore cannot create dopamine, so on and so forth. And then tooth decay. So a lot of individuals with substance use disorder have more dental cavities, tooth loss, and periodontal disease than the general population. And the reasons for that is oftentimes the poor diet when we are using substances, having a dry mouth, grinding our teeth, and neglected hygiene. Again, using myself as a personal example, I am actually living with dentures because of the damage that I did to my teeth, neglected hygiene when I was actively using, and I know I'm not alone also in my community of friends. So it is a very real problem. So what does malnutrition look like in early recovery? So some of you may already know this, but substance use and eating actually share brain circuitry related to reward and motivation. So when we deplete the dopamine in our brain, oftentimes the substance takes the place of dopamine and gives us that quick feel-good feeling. Well, in early recovery, food can often replace that substance and provide us with that feel-good feeling. That's known as addiction transfer. So instead of coping with stressors using a substance, we start using food to cope. And so like in that little picture there, that little image, obviously, you see hamburgers, donuts, cakes. Who doesn't love those things, right? But those are feel-good foods. And there's a reason why there's that stereotype of being sad and eating a gallon of ice cream, because again, it makes us feel good in the moment, but in the long run, not so much. So in early recovery, individuals often have dysfunctional eating patterns because we are transferring one addiction for another, because we are trying to get that feel-good feeling because we don't have the dopamine in our brains to help us get that feeling naturally. So those cravings are often satisfied. Oh, and then cravings in early recovery are often satisfied by foods high in fat and sugar. And so oftentimes in early recovery, individuals will make the comment that, we do need sugar and it's okay to have some candy on hand. And it absolutely is. But at the same time, we need to make sure that we're consuming in moderation and consuming, there are healthy sugars out there that we can get to satisfy those cravings. And they have come to find that individuals who maintain long-term recovery eventually do develop adaptive, healthy eating patterns along the way. But that's in long-term recovery. So why not get those skills in early recovery to help people get past that early recovery goalpost? And we'll talk more about that here in a little bit. Take another drink of water. All right, so early recovery and malnutrition, like I said, bringing in some actual words from professionals in the field. So basically reiterating everything I just made a comment on. So in early recovery, many individuals demonstrate dysfunctional eating patterns. This includes overeating, binge eating, and using foods, especially those high in fats and sugars, as substitutes for alcohol and drug use. So again, that addiction transfer. We begin to overeat, or we may binge eat because when we're feeling down, or we're coming across a challenge in our life, to get that feel good feeling because we don't have the dopamine to allow us to feel that naturally. So something that we do need to also address is the fact that substance use disorder plays a role in the development of chronic diseases. So already in the United States, Americans are at increased risk for heart disease and diabetes. That's not news. Most people already know that. I mean, heart disease is the #1 killer of Americans. And so 37.78% of Americans live with some form of heart disease. As you might imagine, when an individual is drinking, smoking, and using drugs, that actually will contribute further to heart disease. So an individual coming into early recovery, so imagine it, they're coming into early recovery, they're already at a higher risk of developing heart disease, likely because of not eating proper nutrition when they were using. And if they continue to eat those feel-good foods, in early recovery, they can exacerbate those symptoms and actually develop heart disease. So we need to step in and intervene early to make sure we stop that from happening. Same thing with diabetes. 11.6% of Americans live with diabetes, and people who abuse alcohol and drugs are at increased risk of developing diabetes, especially individuals that are, that abuse or use alcohol. So again, we need to make sure that, yes, while it's nice to have some sweets on hand in early recovery to help with those cravings, there are good sugars out there. We don't always have to be eating, chocolate bars. And as much as I love candy, we need to be conscientious. So now we're going to segue into food insecurity. So what is food insecurity? And again, just give you the verbatim definition here from the USDA. It is the condition of not having access to sufficient food or food of an adequate quality to meet one's basic needs. So what is food of adequate quality? So think of it this way. Yes, we live in the United States, a country of excess. And that being said, yeah, you might be able to go to the gas station on the corner and pick up some Slim Jims and a bag of Lay's and an energy drink. But that's not food of adequate quality, even though it may feel good at the time and it may fill your stomach. That's still considered food insecurity because you don't have access to quality nutrition, and regularly consuming those items will contribute to malnutrition. So food insecurity, the USDA actually breaks it into kind of a scale. So it's from food security to not having food insecurity. And I'll just kind of, read these a bit verbatim. So high food security is having consistent access to enough food at all times. So think about living in, not to pick on the suburbs, but like a nice suburban neighborhood with a grocery store on the corner that has a bike trail to it. They have high food security. Marginal food security is when an individual occasionally worries about running out of food, but it doesn't really happen. Like they may kind of get low on some supplies, but they can take a trip to the grocery store, pick up some more. It's okay. Low food security is when an individual has reduced quality, variety, or desirability of a diet. So again, that's where we're saying, yes, they can go to the local corner store, but they're not going to get healthy options there or much variety. And oftentimes these individuals do run out of food before they can purchase more. And then very low food insecure or very low food security is when there are multiple disruptions in eating patterns and food intake. So again, maybe you don't even have a corner store that you can go to pick up groceries on the fly. You have to wait for a bus. And between all of that happening, your shelves at home are empty. And so that's what's meant by very low food security. I'm not going to read all of these questions. I would not do that. But so the USDA actually, well, as of right now, still gauges food security and food insecurity in the United States. Things may be changing in the future, but I'm not here to discuss that component. But I will say that right now, those first two questions on this slide that are highlighted in blue are questions that most people are familiar with. I don't know about you, but when I go to the doctor for my annual physical, these two questions come up in my survey that I have to fill out before the physical. The first question is, we worried whether our food would run out before we got money to buy more. I always feel like that's so awkward to say, but that's what the question says. Or it's more so stated as a statement, and then an individual will say that's often true, sometimes true, or never true in the last 12 months. So mind you, these questions are based on 12-month increments. The second question is, the food that we brought just didn't last, and we didn't have money to get more. And then, was that often true, sometimes true, or never true? Often from those two questions, you can determine somebody's food insecurity level. But of course, there are 10 questions in total that can help an individual or help somebody assessing an individual's situation dig a little bit deeper. So there is a misconception in the United States that oftentimes people are like, well, food insecurity, there are food pantries everywhere. So food insecurity must be a personal problem, right? If there are food pantries, on every corner, and there are plenty of food pantries in Marion County. But still, that doesn't necessarily mean that they're accessible. So here's the reality. Most food pantries have restrictions. A lot of food pantries require you to have an ID. So if you don't have an ID on you, and a lot of people that were previously unhoused or coming out of incarceration may not have access to those documents. A lot of food pantries have frequency limits. You can only go so many times a month, sometimes only once a month. How long is that food going to last you? Food is also a limited resource. And recently, due to changes, there's also even more limited funding for organizations that have food to acquire food to give away. And then transportation is a barrier to many of these food pantries. I mean, you think about the physical capacity needed to go to a food pantry, get 30 pounds of food, carry that back to the bus stop, get on the bus, get off the bus, and carry that back to the home. And again, sometimes people will say, well, again, people just need to, get over it and go do it. That has a lot of physical capacity and physical needs to it. So the personal variable has a very minimal role in food insecurity. The hard reality is this: food insecurity is significantly more common among people with substance use disorder than our general population. 40 to 70% of people with substance use disorder experience food insecurity, and that includes people in early recovery. The national average is 12 to 13%. So look how bloated that number is. 40 to 70% of people with SUD are experiencing food insecurity, and that's a problem that we need to address. And it's often one that we, for one reason or another, may choose to ignore or just completely overlook. But we need to address food insecurity among people living with substance use disorder and early recovery. Anyway, I'll get off my soapbox. So what are some risk factors for food insecurity? And I'm going to ask you to kind of pay attention to these because this is going to come up later, and you'll see why. So it's important for us to remember that food insecurity is the result of numerous variables at play, right? So you may fall underneath one of these risk factors, or all of them may be playing together. So a risk factor for food insecurity is living near or below FPL, and I'll define what that is in 2025 later on in the presentation. It can be a result of being unemployed, because if you're unemployed, obviously you're not able to bring in the finances to procure the healthy food that you need. It can be dependency upon SNAP and food stamps. And what that means is, well, right now it's even more difficult than ever to receive those benefits, but it's also, there are limits on how much you can spend, all those fun things. So that also contributes to food insecurity. And then living with severe mental illness or co-occurring disorders often that can contribute to factors such as being unemployed, right? And then that leads individuals to living near or below FPL. So all of these factors play against one another, play with one another to contribute to food insecurity. So how does food insecurity show up when an individual is actively using or living in substance use disorder? So as you might imagine or know, substance use disorder drains financial resources, leaving an individual with less money for food. And in that way, it contributes to housing instability and job loss, contributing further to financial insecurity. The way that I kind of look at this, and as a person in recovery as well, is an individual may prioritize and often does prioritize the substance over everything else, which kind of goes into that third point. A person will purchase the substance over purchasing food, and they will put all of their financial resources, as limited as they are, often into doing so. When doing that, then they may lose their home, and contributes to other components in becoming unhoused. Substance use disorder can actually suppress appetite and disrupt absorption. So, when you're using substances, it can affect your GI tract, which will then affect your ability to absorb nutrients. And then symptoms of substance use disorder, such as, that fatigue, that withdrawal, they can make it difficult for an individual to shop, cook, or store food. Take a quick swig of my water here. So substance use and food insecurity, continuing on. So having a lack of transportation or access to a kitchen obviously makes it harder to store food and eat healthy. If you don't have a car, it's not convenient at all to go to the grocery store to get the food that you need. And again, if you are prioritizing a substance over utilities and bills, you may be unhoused or your utilities may not be on. So storing food is just really not an option. Oftentimes, people with substance use disorder may be excluded from food assistance programs. There is a stigma associated with substance use disorder. If somebody shows up to a food pantry and they may be experiencing withdrawal or actively on the substance of their choosing, they may be turned away. And so they may not get that food that they desperately need. And then food insecurity intensifies health effects of substance use disorder. So by contributing to malnutrition, we already know that individuals with substance use disorder often have weaker immune systems. Being malnourished contributes to that even further, leading to higher infection rates and infection risk. Individuals that are malnourished as a result of food insecurity have increased hospitalizations, and it takes them longer to physically recover. So as I mentioned, I will continue to pull from the professionals here to kind of confirm what I've already said. But the first one here is that people with substance use disorder are often at an increased risk of food insecurity due to their chaotic lifestyles, unstable housing, and limited finances, as well as their previous and ongoing health problems. And then substance use disorder modifies eating habits, including an irregular eating schedule, eating fewer meals per week, skipping meals, fasting to prolong the effects of drugs, eating late at night, and eating alone. So obviously substance use disorder contributes to dysfunctional eating patterns, and those dysfunctional eating patterns do linger in early recovery. And they, like all other consequences of substance use disorder, need to be addressed. Before an individual can focus on higher level needs, we often talk in recovery about needing to change a personality, needing to, embrace change theory, right? Before an individual can reach that stage, they need to have their basic needs met. And I feel like in the social work field and in the field of psychology and in recovery, that's commonly known, but not often addressed. So what I mean by that, and so for those of you that may have a social work background, psychology background, sociology, heck, I feel like a lot of people these days are familiar with Maslow's hierarchy of needs, but just because we're familiar with it doesn't mean we always look to it and really understand what Maslow is trying to say with this hierarchy of needs. So recovery requires a lot more than just motivation, insight, and personality change. It requires meeting one's basic needs first. You need a stable foundation before you can address those psychological and self-fulfillment needs. Those are prerequisites to sustained recovery. And so those first two levels are your basic needs, right? And those are food, water, shelter, sleep, transportation for essentials. And then your safety needs is stable housing, financial security, and access to healthcare. And I feel like in the recovery world, we've come a long way with being able to provide individuals with housing, but we still continue to overlook nutrition. Again, there's a difference between food and nutrition. Food is any old thing to fill our stomach. Nutrition is eating the right kind of food to gain, to be healthy and to support our recovery. And then, of course, those psychological needs is that, social support, emotional regulation, and that self-actualization is that pinnacle of the pyramid where we gain those coping skills and we begin to identify who we are and to make changes that are needed. So if programs or systems prioritize personality change, coping strategies, or therapies over basic needs, people may struggle to apply the tools that somebody is attempting to teach them. You can teach coping skills, but if someone doesn't know where they'll sleep tonight or how they'll get to work or what they're going to eat next, those skills will not stick. So we're going to dig just a little bit deeper into food insecurity. And since I work at Meals on Wheels of Central Indiana, I'm going to specifically focus on Marion County. Food insecurity is throughout the entire state of Indiana, but as you might imagine, with Marion County being the most populated county in Indiana, the highest rate of food insecurity is here, with 19.4% of the total population of Marion County being considered food insecure. A significant portion of this population lives in what are considered low-income areas, or zip codes. So this table, actually on the left of the slide here, shows the 10 zip codes in Indianapolis with the lowest per capita income. And so I put some reference on the side here. What do I mean when I say per capita income? Per capita income is the total income of individuals in a specific area divided by the total number of residents. So for example, this 46241 zip code, this is saying an average individual. If you live in the zip code, this may not be reflective of you, but it's saying that the average individual in the zip code makes $20,359 per year. So I want to put that into perspective that the federal poverty line right now is 2025 is $15,650 for an individual. Again, to put that into even further perspective, in order to live comfortably within Marion County, an individual must be making at minimum $44,804 a year. 20,000 is well below that, as you might imagine. And so that's what that percentage of FPL means. That means how close that number is to federal poverty line. Now, again, these are the 10 lowest zip codes throughout Marion County. If you notice here, the east side and midtown areas of Indianapolis are disproportionately represented, reflecting the highest concentration of low-income zip codes in Marion County. When the per capita income relative to FPL is average across those 5 east side zip codes and the 2 midtown zip codes, it equates to about 147% of FPL. As of 2024, like I said, or 2025, the average individual income, in these areas was $22,050. So although the cost of living in Marion County is lower than the national average, which I believe is about 60, an individual still has to earn at least $44,804 to live comfortably. And please know, when we say live comfortably, I don't necessarily like that term. It basically means being able to meet one's basic needs. That leaves no wiggle room for fun, play, and socialization. So I don't know if I like the term comfortable living, but that's often how it's referred to. So residents that are living within Midtown or the East Side typically earn well below the income required to meet their basic living expenses, indicating widespread financial instability. Since zip codes in these areas are classified as low income, housing tends to be more affordable in these areas. So you'll often find that there are lots of recovery residences in these areas for many good reasons, right? Because a lot of individuals with substance use disorder, there's a higher percentage in these areas, but also because housing in these areas is more affordable than it is in some of the more, if you want to use the word, affluent neighborhoods in Indianapolis and the surrounding counties. So let's take a look at where some recovery residences are located in Marion County. Now, this is Marion County proper. This map may look a little funky. To give you some reference, I pulled this information. There is it's called Open Indy. It's a portal where you can look at needs and resources throughout the city, and also Savvy. And I also used information from the Department of Mental Health and Addiction to locate where recovery residences are throughout Marion County. Mind you, these are only the ones on DMHA's website in addition to Oxford House's website. So I'm sure there are plenty that are not represented in this map. So I apologize for that, but I used the best information and resources that I could get. So the map is broken down. The red areas all represent different zip codes throughout Marion County. And the areas that are shaded in blue are those 10 zip codes that are considered low income. And if you notice here, there is a large concentration of recovery residences located in those low income zip codes. And the issues and barriers faced by individuals living in those zip codes are also faced by individuals living in recovery residences within those zip codes. So, to give you a little bit further information on this. So due to those, so this table, sorry, let me slow down here. So this table actually, similar to the table that I showed you before, it breaks down the different zip codes and shows you the number of recovery residences based on the information I had available that I just talked about in those areas. So you'll see there's plenty in 46205, 46208, and 46219, and the others are kind of just spread evenly with some not having any at all. And like I already mentioned, barriers faced by individuals in low-income zip codes are also faced by the individuals living in recovery residences within those zip codes. To kind of put this into perspective, within those low-income zip codes, about 30,000 households lack transportation. They do not have a vehicle. And again, that's often reflective of the recovery residences as well. A lot of these low-income areas are also considered food deserts. Because they are considered low income, grocery stores and other businesses often choose not to establish operations within these areas. As a result, residents have limited access to nutritious food options and stable employment opportunities. The few grocery stores and businesses in these areas struggle to remain viable and often relocate to more economically advantageous areas of Marion County. During the mid-2010s, numerous establishments in Midtown and the East Side, most notably Marsh supermarkets, permanently closed. These communities have yet to recover. Consequently, many neighborhoods within Midtown and the east side of Indianapolis are considered both food and financial deserts. Although the expansion of recovery residences in these underserved areas is well-intentioned, their placement results in residents being further isolated in neighborhoods lacking essential resources. These challenges are compounded by limited public transportation, access throughout Midtown and Indianapolis's east side, both of which are highly car dependent and lack sufficient bus routes and sidewalks. So although transit initiatives like Indigo's red, purple, and blue lines are improving connectivity, reliance on fixed route systems remains a barrier for many residents. Individuals living in recovery residences in these areas, again, lack access to personal vehicles, which often makes it difficult to reach grocery stores that offer quality nutrition or businesses providing stable employment. So that is the reason that, again, pointing all of this out. And it gets, oh, by the way, food desert. Just to define that, the USA defines a food desert in an urban area as a location where residents in that area must walk 1+ mile to get to the nearest grocery store that has quality, nutritious food. So going to break this down a little bit further. So it's the same map that you saw before, but this time you'll notice there are these big purple splotches on top of it. These purple areas, thanks to the Indian Hunger Network and other resources, I was able to locate what are considered food deserts and put them over, the low. And what you'll notice is a lot of these food deserts are over the low income zip codes. And again, one thing that you're going to notice as well is a large concentration of recovery residences exist within these food deserts, meaning that if an individual lacks transportation, they have to walk 1+ mile to get the food that they need, or rely on rides from housemates, or if the residence has a van, use that van to get to where they need to go. So if you remember earlier, I asked you to remember the slides about food insecurity and the risk factors. So how does food insecurity show up in early recovery? So a lot of these numbers that I'm giving you are going to be estimates because, as you might imagine, with recovery being, with recovery the way it is, it's very difficult to survey the population due to the transiency of this population. So a lot of individuals in early recovery are considered financially insecure. About 81,000 persons in recovery from substance use disorder in the state of Indiana are Medicaid enrollees. And in order to be a Medicaid enrollee, you must make 138% below FPL. So considered, again, living in poverty. 30 to 50% of persons in early recovery are unemployed. So that specific number, actually, there was an employment survey that was done on this particular population by the Indiana Business Review, and they found that 57.5% of people in recovery are employed, leaving the remaining 42.5% as unemployed. So that 30 to 50 is an area or a cushion for margin of error. They also found that 23% of people in early recovery received some form of government assistance. As you might imagine, government forms do not track whether or not somebody has substance use disorder. So this was an estimate made based off available data and evidence. And then lastly, 50 to 60% of adults treated for substance use disorder are co-diagnosed with another mental health disorder. In fact, the Indiana Family and Social Services Administration reports that co-occurring disorders are the rule rather than the exception among people seeking treatment from substance use disorder. So all of this to say that individuals in early recovery are at a huge risk for experiencing food insecurity. And as I've already mentioned time and time again, but I will iterate this point over and over because it's important, the problems faced by residents in low-income neighborhoods, which you saw that map earlier, and there are plenty in Indianapolis, are also faced by individuals with substance use disorder living in residences in those areas, or living on their own in those areas. Residents in early recovery often live in poverty. A lot of them are coming out of being previously unhoused, coming out of treatment, coming out of incarceration. Due to the stigma associated with substance use disorder, many of them are not able to find well-paying jobs. They may find a job, but that doesn't mean it's well-paying and can meet their basic needs. And then residents in early recovery often lack access to reliable transportation, which means they often will rely on other residents to provide transportation, or the residence itself may provide transportation, but on a fixed schedule. It's not as needed. So how do we address food insecurity among this population? Because you might be like at this point in the presentation being like, okay, well, right now this all seems kind of like unfortunate news. Like where's the hope? What are we doing to address these needs? And so thankfully I can say that we have made progress and we are making progress. And actually all that to say, so poverty stats and food deserts, all that information you just saw, that's only half the picture, right? Numbers are great. Numbers say a lot, but we need to move away from the numbers and start asking, first off, residents living in these residences, which is difficult due to the transiency of the population. So one thing that we can do is talk to recovery professionals working with these populations. So in 2023, Meals on Wheels of Central Indiana, we actually reached out to professionals working in the recovery field with a focus on recovery residences. So those working in recovery residences throughout Marion County. We actually sent out a need survey and we did some in-person interviews as well. INARR helped us disseminate that. So did Mental Health America of Indiana. So we did get lots of feedback. In those surveys, we asked a variety of questions. I'm not going to go through all of them, but one question was, on a scale of 1 to 4, how would you rate the need for nutritional or food services within the recovery community, specifically for persons in early recovery, which we at Meals on Wheels are defining as the first 90 days. In this survey, 71% of respondents said that there was a significant need for nutritional and food services within the recovery community. Now, I have to do my due diligence and point out the outlier here. So you'll notice that more individuals said there's no need for it than those who said little need or other needs. So it's where were these responses coming from? So I did a little digging, and like I said, this survey went out to everybody, working in recovery residences. And as we know, there are some recovery residences, if you look at the levels defined by, I think, the National Association of Recovery Residences, that are like level 4. Those residences often have wraparound services, full industrial kitchens, meals being served throughout the day. So yes, individuals working in those facilities may say there is no need for nutritional services because what they are experiencing, they may presume, is just the normal experience for all residences, which we know is not the case. So another question that we ask is, on a scale of 1 to 4, what role do you believe nutrition plays in a person's recovery? So 81% of respondents said they believe nutrition plays a vital role in a person's recovery, especially during the first 90 days. And so, sorry, keep taking a drink. Another question that we asked along the way is, have you ever experienced, because remember, these individuals are working with people in early recovery, literally coming out of being unhoused or out of incarceration or out of a treatment facility. So they really get to see these struggles that they have in their early journey of recovery. And so we asked, have you ever experienced or witnessed a person with substance use disorder in early recovery struggle to access and purchase nutritional healthy food? And so 85.7% of respondents said absolutely, they had seen that. So we can acknowledge that nutrition is important, but we also are acknowledging the fact that many people in early recovery can't afford to purchase the food that they need to recover and to help their bodies physically recover and their minds recover. That's a bit of a problem. And of course, doing our due diligence as well. We didn't just ask quantitative questions. We also asked qualitative questions or open-ended questions. And one of those questions was, what are barriers standing between persons with substance use disorder and early recovery and access to nutritional, healthy food? And it's literally all these responses. And one thing I love are the things that I just covered. So the evidence iterates what people in the recovery field are also saying. So financial challenges, poor food choices in the communities they live in as a result of living in food deserts, lack of education on a proper diet, increased intake of junk food as a symptom of post-acute withdrawals. So I love these responses that we got. I'm not going to read through each of them for the sake of time, but I will say again, I did want to point out the outlier on this. So the very last one, italicized, says, in our program, all food is provided with shared access. That last comment is from an individual working in a level 4 residence with wraparound support, such as an industrial kitchen, access to food throughout the day for residents, and more. So it could be that again, that individual, there may be a bit of a disconnect or a misunderstanding that these services are offered in most recovery settings, which we know is not the norm. So one final question that we asked is, what are your thoughts and recommendations on how we can address food insecurity and malnutrition among the target population? And this person, I don't know who they were, but they gave us a wonderful response, very informative, and I'll just read it verbatim. Some recovery residences are DMHA certified and are required to provide access to food for residents to prepare themselves. However, due to limited resources, sometimes this food is not necessarily the best quality or the most healthy. Some residences are able to hire and maintain kitchen staff, which may result in better or more healthy and balanced meals. Those would be your level 4 facilities. Initiatives should focus on recovery residences who do not have kitchen staff and residents who may not have the basic skills needed to plan and prepare meals. There should be an educational component for teaching these basic skills so residents in recovery understand nutritional needs and how to find and prepare foods that meet those needs. Wonderful response. This person obviously helped us lay the framework for a program we have here at Meals on Wheels, which I'm literally about to talk about. But one thing I did want to mention is they talk about how DMHA certified residents are required to provide access to food. And I have come to know along the way with this program that we have that there are plenty of residents that do have food pantries on site for their residents. And a lot of these food pantries are stocked by alumni of the resident, which is just absolutely amazing. However, working in the food business at Meals on Wheels, one thing that I know is that oftentimes when food pantries are reliant on donations from individuals are more prone to donate items that they don't want to eat, and those are often items that are high in fat and sugar. As much as we all love Chef Boyardee, it's not necessarily the best thing to be eating for lunch every single day. And so like at Meals on Wheels, we actually don't often take in donations from the public, for the simple fact that we want to make sure that our pantry is full of low fat, low sugar, low sodium goods. And so again, while that food may be available to residents, it's not always the best quality food. And so initiatives that do focus on nutrition need to focus on residents that don't have those full-fledged kitchens. There are actually a couple of level 4 residences that have kind of transition programs where individuals will move into apartments. So while this individual may have been receiving, 3 full meals each day while they were in like that big level 4 residence, when they transition out, that's when they may begin to struggle with food insecurity. And that's when we at Meals on Wheels have an opportunity to step in to assist. That's a perfect segue to talk about our No Limits to Recovery program. So I spent a long time talking about nutrition, how nutrition interacts with substance use disorder, malnutrition, food insecurity, all the problems faced by people in early recovery, all the variables playing into food insecurity and malnourishment. And so what the heck are we doing to try to address this problem and to provide people with their basic needs in a way that meets their dietary needs as well? And that's where you get No Limits to Recovery. And so know your eyes do not deceive you. The NO in No Limits is capitalized for a very specific reason. The NO in No Limits stands for Nathan, or as we call him, Nate Atolsky. So Nathan Atolsky was a coworker here at Meals on Wheels of Central Indiana, and also a very close friend of mine. Like I said, I'm a person in recovery. I knew Nate both as a coworker and also as a person in recovery. When Nate was working here, he was getting his major in business. I think I don't think he was at his MBA yet, but he was majoring in business. Loved what he did here at Meals on Wheels. Was very passionate about the organization. And oftentimes here at Meals on Wheels, we walk around and talk to each other. And, I would talk to Nate often. And at Meals on Wheels, we have an opportunity where we serve a variety of populations. So we don't just serve senior citizens. We serve people living with HIV and AIDS throughout the entire state. We serve individuals living with cancer. We serve basically anybody and everybody. So Nate and I, being people in recovery, started just talking like, wouldn't it be cool to serve people in early recovery? Now, the thing about Nate is Nate had lots of experience actually living in recovery residences throughout Marion County. He'd been, I say lots, he had been in a handful of recovery residences throughout Marion County in his own journey. And one thing that he had told me is that, one of the most common fights that he experienced in recovery residences are when somebody would eat somebody else's food. And then the other thing that he told me is that he often would see people go without food, that couldn't afford to buy food, that were putting all their money towards paying for their rent, and for their share of the utilities. And so he was like, let's serve people in recovery residences. Unfortunately, in March of 2022, Nate did die by overdose. It definitely impacted our organization, and it was something that we're still working with today. But I will say one thing that I am grateful for is after that occurred, I went to our supervisor, our CEO, Jamie, and said, hey, this is the idea that Nate had. What can we do to make this happen? And she was fully on board. And so, kind of segue into the philosophy behind the No Limits program. Instead of giving you a block of text, I have a weird chart here. Hopefully it makes sense, but I will read through it as I'm going through our philosophy here. So we believe that by providing individuals in early recovery with medically tailored meals, we reduce food insecurity, which then improves nutritional health. We relieve them from the burden of wondering where their next meal will come from. Additionally, medically tailored meals decrease digestive discomfort. Remember, GI problems are common among substance use disorder individuals diagnosed with SUD, and that we will increase energy levels. And by doing that, we will contribute to improved mental health and obviously improve physical health. And those things will contribute and establish long-term coping mechanisms, contributing to greater long-term recovery outcomes. That is our philosophy, and that is what the No Limits to Recovery program is built off of. So when we started thinking about this idea, we had to ask ourselves, okay, so who is this program going to be for? When you're developing a program, yes, you would love to feed everybody, but funders want you to be very specific, right? So we had to really specify who it is that we wanted to focus on. We wanted to focus on individuals in early recovery, and we defined that as the first 90 days of recovery. Now, with the program itself, we focus on the first 90 days of residency, but we'll come back to that in a little bit. They needed to be living in recovery residences throughout Marion County. Again, Meals on Wheels of Central Indiana, we primarily serve Marion County, so we wanted to start local as we're professionals at working with populations here in the city. And then they needed to have one or more of the following conditions to be met. Living near or below FPL, that's federal poverty line or level, considered food insecure and are malnourished. Remember, they both play into one another. And then living with some form of chronic illness, such as heart disease, diabetes, etc. And then, of course, what services? So we're like, what are we going to provide them? So of course, we had thought about this as well. And so what we wanted to serve them are medically tailored frozen meals. Those are low sodium, heart healthy, renal diet, so on and so forth. And we wanted to serve them with medically tailored pantry boxes. And those are pantry boxes, again, with low sodium, low sugar items within them. And then, of course, that educational component that was suggested to us, we wanted to provide them with a Cooking Matters class, a class that they could come to learn how to cook with healthy, affordable ingredients, and then get to take those ingredients home with them. And then as we started thinking about things further, while the staff here we have an amazing team here, we wanted to bring staff on board that could better relate to and connect with individuals in early recovery with substance use disorder. So we started thinking, wouldn't it be great if we had a peer recovery coach kind of running and coordinating this program? And then we started thinking, wouldn't it also be great if that individual could connect these people with recovery and harm reduction resources? And then, of course, to make sure that the impact of the program, that we have proof of the impact, we thought, well, we need to have some kind of assessments done along the way. So we have our nutrition and mental health assessments that we do. So these are all the ideas that we had. And then for how long? Unfortunately, funding does not last forever. And so you do have to specify how long a service should last. And so again, if we're going to help people within their first 90 days of recovery or residency, then we said, okay, well, that's 90 days of services. 90 days is often the amount of time it takes to change a habit. 90 to 107 days, the number is always changing. You'll hear different things each week. And then the regular assessments that we would perform them at intake, 30 days of service, 60 days of service, and 90 days of service. And then to do our due diligence to get feedback, we would do satisfaction surveys at 45 days of service and 75 days of service. And then where are we going to focus on this population of individuals in early recovery living in recovery residences? Like I said, we said, okay, well, let's begin with what we know. Let's start with Marion County. And that is currently where we are. And that is where our funding allows us to be. Now, eventually, it's not, I say I would like us to, instead of use the language, we will eventually serve all of Indiana. It is a matter of finding funding to be able to do that, which I am not doubtful we can find. And then eventually my aspiration is to see this model implemented across the nation or even beginning elsewhere in the Midwest, really helping people address the fact that quality nutrition needs to be the basic foundation for a strong recovery right alongside affordable housing. And then how are we going to deliver these services? Well, we're going to have frozen and pantry drivers. They're going to deliver, we have those actually on our staff. They would deliver these frozen meals and pantry boxes to clients throughout Marion County. We would have a program manager that would oversee implementing the program, analyzing data coming in and establishing partnerships. And we would have a peer recovery coach working with clients, doing one-on-one coaching sessions as needed, doing intake and follow-up assessments, and much, much more. And so that was our dream. We pitched all of those things that I just said, the who, what, when, where, and how, to numerous funders. And the good news is that in 2024, we received funding from the Richard M. Fairbanks Foundation. That funding is to stretch from 2024 to 2026. We received about $137,350 from them, which we are immensely grateful for. A few months later, the Division of Mental Health and Addiction caught word of what we were doing and provided us with administrative support, which we are very grateful for. And then we continue to receive donations from generous donors. It is easy to donate to the No Limits program. It's on our website. You can donate, and you can donate specifically to the program as well. So once the program is funded, obviously the hypotheticals had to become realities, right? And so this is what the No Limits program is. This is the design of the program. So the services that we provide our clients, we provide them with 10 quality, nutritious frozen meals once a week for 90 days. That's about 130 meals in total. I do want to say that these meals are actually provided by Herculean Meal Prep, as you can see in this beautiful picture here. If you're not familiar with Herculean Meal Prep, they have a location at the garage at Bottle Works in downtown Indy. They also have a few stores throughout the Indy area. Wonderful frozen meals. If somebody warmed one up for you and took it out and put it on a plate, you would never know that you were eating a frozen meal. I'm not just saying that because they serve our clients. I mean that. I love their meals. And actually, Ben Canary is a co-owner of Herculean, and he's given me his permission to share this story, but he is also a person in recovery. So we have meals being made by people in recovery for people in recovery, which is just a wonderful full circle thing. We also provide clients with one medically tailored pantry box per month for 90 days, which comes to about 3 pantry boxes. And then after 60 days on the program, they're eligible for a Cooking Matters class. At this time, due to some funding constraints, we do offer that class 2 times a year, though as the program continues to grow, I would love to see that offered more frequently. The services are delivered, like I mentioned, by our frozen and pantry drivers. They deliver in our vans, and they deliver Monday through Thursday. And then we do provide peer coaching services right now, and I'll introduce her here at the end. We do have our program manager who also acts as our peer coach. And we also are looking to bring in some peer coach apprentices and interns to get their hours in. And then we collect data through a nutritional risk assessment and patient health questionnaire 9. For those of you that are in the field, you may know that the PHQ-9 is used to assess symptoms of depression. So we look to see how their mental health is improving or not improving over a span of time. We assess them at intake, 30, 60, 90 days of service. And then, of course, we do a satisfaction survey at 45 days of service. You'll notice that initially in the framework, we had 75 days as well. We realized that there is such a thing as calling people too much. And so we removed that survey, knowing that we could get the information we needed from just the 45-day survey. And the length of services, it lasts for 90 days, which is about 12 to 13 weeks overall. But wait, there's more. So we do more than just deliver food. And that is very important, by the way. We're not just delivering food, we're delivering nutrition. Clients also receive a peer coaching session during their first 30 days on the program. However, if a client is in a residence that already provides peer coaching, we do waive that. They don't need to receive dual peer coaching. But we do provide that to individuals that don't have that opportunity elsewhere. We provide them with welcome kits that include Narcan, thanks to our partnership with Overdose Lifeline. We have doTERRA drug deactivation kits from Cahoots. The American Foundation for Suicide Prevention has given us a handful of resources to give out. Again, Overdose Lifeline has given us brochures to give to clients, as has Damien Center's Harm Reduction Department. So they get a bag full of resources that they can connect with as needed. And then thanks to a generous corporate sponsor, we have some wonderful hygiene kits that we are currently giving to our clients. You can see the items. I mean, they're not just like your travel size. They get like full-on shampoo, body wash, shaving cream. It's wonderful. So we provide those to our clients as well. So how is somebody eligible for this program? Again, I briefly talked about it early on, but just to kind of get into it here a little bit. First off, the referral form can be accessed at our website at that www.mealsonwheelsindy.org. Underneath the program tab on our website, if you click on No Limits to Recovery, the referral form is in there. I will give a heads up, since this is a recording, our website will be changing in the near future and looking a lot better than it does now. So that location may change, but I will do my best to make sure that it remains under the No Limits to Recovery tab, wherever that may be moved to. So to be eligible for the program, so upon receipt of services, the client or the person being referred needs to be within their first 90 days of either getting ready to move into a recovery residence or already living in a recovery residence. Again, right now, due to funding restrictions, that does have to be within Marion County. And then in addition, one of these three conditions needs to be met. Again, just one of these three. Oftentimes it's more than just one, but just one needs to be met. The client needs to be eligible for financial assistance programs, in the process of applying for financial assistance or already receiving financial assistance, or the client is at risk of malnutrition, often due to food insecurity, living in a food desert, not having transportation, etc. Or the client is living with one or more chronic illnesses like heart disease or diabetes. Again, like I said, a lot of our clients come through and they meet all three of those criteria, but it just needs one in order to be eligible. Now, reasons for termination. Why would we terminate a client prematurely? We don't want to. Long story short, we don't want to do that. However, because of the way the funding is structured, if the client moves out of a recovery residence or is evicted from a residence and does not move into another recovery residence, then those services are terminated. We also do have to terminate if a client does not follow up in follow-up assessments. So we will reach out to them, but if we cannot make contact with them, that is another reason we will terminate or suspend their services. Some lessons that we have learned along the way is that we really do need clients to have some kind of working cell phone, or since we know some residents do take away cell phones during the first 30 to 60 days, we just need to have a house phone where we can be guaranteed to reach that client to do our follow-up assessments. In addition to that, the referring party must provide their contact information. So on the referral form, there's a section for the person referring to put their information. Please, 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 if you do fill out the referral form, put your information on there. So if we do have an issue reaching the person you've referred, we can reach out to you and get that straightened out. So enough about the program and what it does. Let's talk about the impact that it has currently had. So the raw impact thus far looks as follows. So the total number of clients that we have served since the program started in July of 2024 is over 120. I didn't get an exact number, so that's why there's the plus there. The total number of frozen meals delivered as of the beginning of this month was 11,510 meals. That's a lot of frozen meals, by the way. The total number of pantry boxes delivered is 249 boxes. That's about 6,225 pounds of food. That's a lot of food. And guess what? That's food that the person doesn't have to go to the pantry to get and carry all the way back to their home. It's delivered directly to them. The number of peer coach contacts that we've had with clients, that's the number of times our peer coach has called clients, spoken to clients, resolved issues, is more than 1,200. It's a lot of phone calls. And then the number of hours that our peer coach has had with clients is over 120, because again, it matches typically the number of clients that we've served. So what is the calculated impact? This is the stuff I nerd out on. Not everybody's about numbers. So I'm going to try to put this in like a way that's just not all numbers. But like I said, we do assess clients at intake, and then we assess them at 30, 60, and 90 days to see if things are improving. And what I love to report is that the numbers show that things are improving substantially. So we've done about 120 intakes since the program launched. The average nutritional risk assessment score at intake is an 11.09. And what that means is they're at like moderate risk of malnutrition, which is concerning. At 90 days, that score is lowered to 6.84, which now they're on the borderline between low risk to moderate risk of malnutrition, which is a huge improvement. That's a 4.25 point improvement, which is just amazing. The PHQ-9 score. Again, that survey is associated with depression, symptoms of depression. What we have found is that intake, people are scoring about a 6.62, showing mild symptoms of depression. At 90 days, they're showing a 3.76 score. What that means about none to very minimal symptoms of depression, which is a 2.86 point improvement. Again, those are numbers. All of that, to wrap that up, what we're seeing is we are seeing significant improvements in individuals' nutrition, and we are seeing, I would say, significant improvements in their overall mental health, especially related to symptoms associated with depression. But more importantly, how many people are graduating from the program? So on average, and this number is kind of changes depending on the source that you're going to, but on average, people tend to agree that about 40 to 50% of persons with substance use disorder relapse within their first 90 days of recovery. So far, out of all the clients we have served, 60% of clients have graduated from the No Limits program, which means 60% have surpassed that 90-day hurdle, which is amazing. That is over that average, that the national average of that relapse rate, which is just, it's amazing to see that many people graduating and taking these skills with them. But again, numbers and data and all that, that's all wonderful. But what are people actually saying? And so these testimonials are actually a little old. When I was putting this slide together, it's like, I really would like to get some more recent testimonials. Either way though, these are amazing testimonials, and I'll just read a few to you. So the one right here. So when I was at a recovery house in the past, this program, like the one you all have, wasn't a thing. Back then I relapsed. Your program made coming back easier. It helped me build a routine and get used to living a normal life. It made it simple to grab a meal and do the other things I needed to do, like go to work, meetings, and more. I'm glad this program exists to help other people like me. And I love that. Because the great thing about these frozen meals, right, like this person is saying, is it makes it convenient, right? They can take the meal with them to work. They know that they're always going to have a meal on hand, a nutritious meal on hand, so they can do what they need to do, like go to work, focus on meetings, and come home knowing that there is a meal waiting for them in a freezer and pantry goods on the shelves. Another person said, since starting your program, I've lost up to 12 pounds. Healthy loss of weight, by the way. I'm not sitting around my apartment or eating fried food. Because I've been able to put money aside, money I would have spent on bad food, I've been able to catch up on my bills. I'm in a much better place financially. I love this one because remember earlier I talked about dysfunctional eating patterns in early recovery and how we often turn to those like quick feel-good foods that aren't good for us. This person's literally saying that, like, if not for this program, that's what they would have done. But because of the program, they've learned how to eat better, to focus on their nutrition, and put money aside to pay off their bills, which is just amazing. And then I'll just read one more. And this one here at the bottom, I kind of went diagonal, didn't I? So I love the variety and taste of the meals you send me. Plus, when I need to get hold of someone at Meals on Wheels, it's super easy to do. I also enjoyed speaking with your peer coach because they were super engaged. I could tell they were really listening to what I was saying. I've actually referred some other residents to your program, and that's what we love. We love word of mouth referrals. We love people hearing about us and sending people our way that absolutely need our assistance. And I love that they talked about the peer coach, and that was one of the main reasons we brought that peer coach on, that we wanted a peer coach, is to be able to meet individuals where they are. And that's been made possible through the No Limits program because of partners like you, that we get to serve the people that we get to serve today. And then lastly, and then I will have Allison introduce herself in just a second. So hopefully she's still there. So this is just my contact information. That is a very old picture of me. That's from like 4 years ago. But again, my name is David Carpenter. I am the Director of Quality and Programs. My phone number is there on the screen. My email address has not changed. I do have a LinkedIn profile. You're welcome to visit me there, network if you want to. And I'm happy to answer any questions that you may have about the No Limits to Recovery program. And with that, I will stop sharing. And that's it. Allison, do you want to introduce yourself real quick?
Yes, hi, I'm Allison Freeland. I am the peer recovery coach and program manager of No Limits to Recovery. And I get to work with David on this amazing program.
Thank you, Allison. All right. Well, Kat, that's all I had.